I was heading the department at the time in Beaumont Hospital, which is an 800-bedded hospital in the north side of Dublin. And I know some of our visitors from Mozambique are visiting tomorrow. And we were all prepared for Ebola to arrive in Dublin Airport. We'd done a huge amount of training. I had already had met Dr. Margaret Fitzgerald from Public Health at a conference, and I'd said to her before that if there was any opportunity to do any work abroad, that I'd be interested in doing it. Mainly actually for personal reasons, to try and give something back for the look I've had in my education. So the opportunity then arose in a post-Ebola project. It was the end of the 5% initiative, and the French were looking for an English speaker to go and do some infection prevention control training in Liberia. So Liberia had 10,000 cases of Ebola. They had nearly 5,000 deaths. They didn't realise I spoke so quick. So in some ways the French were better at speaking English than I was. But I agreed to go for what was 2 missions, one in May and one in June. So when we got there then, I was all ready. And I can only give you my honest experience. I was ready, and in my suitcase I had 2 sets just in case I had to look after somebody with Ebola, which was never going to happen because obviously there are terms of reference. I had protein bars in case I didn't get fed. I had a suitcase full of alcohol hand gel and baby wipes in case there was no showers. I had a mosquito net with me. And then when I arrived, of course, it was fine where I stayed. The hotel was fine. I got fed every day. And I realised it was my anticipation of the project was so different to, I suppose, what you see in the media and what you get prepared for in terms of training. So really what we want to do is to fill in the African Partnership for Patient Safety and attend 3 different hospitals and try and, ascertain what their level of patient safety preparedness was and what the resources were. So we completed those. It was difficult. And to be honest, the first visit, it felt like we were doing the wrong thing to ask questions, particularly in Redemption Hospital, which was very, very badly hit. They had 12 staff that died. And we were kind of sitting there asking the director, do you have a microbiology lab? Can you do infection control testing? But actually the people were so shell-shocked after the experience of Ebola that in some ways it didn't feel right to be there asking the questions. That said, we knew we kind of had a job to do in some ways. And I listened actually to what Maeve was saying about this kind of needs versus learning. And we quickly realised after the first day that we just had to listen to the experiences of the staff that had been there. Again, I thought I was going to go over, and I'd done 1,000,000 studying on how to make alcohol gel. And we soon realised that they really had said, stop. There's so many partners here. There's so many people giving specific advice, and we cannot start saturating the information or giving incorrect information. So at that stage, it was very apparent that there was a lot of different and bigger players than ESTHER Ireland that were there. Now, the one really good thing is that ESTHER France, who's now Expertise France, had actually done a lot of work before Ebola. So they had done a huge amount of work on HIV, a huge amount of work people living with HIV/AIDS, and a huge amount of work in TB, and had given a lot of resources to that and to get all the testing done. So that it was really, at that first visit, was very much about establishing the communication again. Our second visit then, of course, we really spent a lot of time trying to find out where we were best fit to help with the education. So we did workshops again, listening to where their needs were. So then, only a few weeks ago, I went back with Dr. Margaret Fitzgerald. So the previous times I'd gone with French doctors. So I suppose it's I know we were asked here to look at the needs. The sharing of knowledge has been really incredible for me personally, and for bringing it back to the organisation, and the challenges that is internationally when it comes to healthcare. In the acute setting, we've become very focused on our small little area. We try and now bring it towards public health, but it's really having the knowledge then of the international scene has been very useful to bring back to my organisation. Again, there has been meaningful change between ESTHER and Liberia in the past. And I could see a really big change with the national coordinated response. But there is that thing, what we want to provide and what they want us to provide. So we said fine. We picked 4 sites. We looked at Buchanan, Beaumont, which were just outside Monrovia, a TB hospital and a psychiatric hospital. But again, they kind of want us to move out to the community because there's been saturation within the main hospitals there. But that's not what the terms of reference of the project is. So that's very difficult. I suppose it's difficult for me to come to terms with that and to appreciate it. And I'm very reliant on my colleagues in global health to show me the way in that. We're running out of time. So anyway, what we can, I suppose, it's very, very short visits, only 1 visit at a time. There's lots of other partners there, but you get a sense they're all going to leave soon. So there is that sense that everyone's there, use your gloves, use your aprons, use everything. But then we're going to be leaving next year because there's going to be something going on somewhere else. And I suppose that's difficult. We have a very small budget, only about 50,000 per hospital. And it's that whole thing, can you implement what or can you sustain what you implement? We have a slow response time, that's what I feel, whether that's true or not. And again, what they want us to provide, is that what we really, I suppose, listening to them as opposed to trying to push what we want to do in terms of infection control. And that's just my experience of it. Thanks very much.